My name is Gunnerson. I'm an intensivist as well as an EM doc. I'm going to give you an update today about our acute critical care research, specifically as it relates to the Massey Family Foundation Emergency Critical Care Center. Now, first thing, the typical disclosure sign, nothing really here. It's going to affect the content of the presentation. Now, Dr. Barsan earlier today talked about the Joyce and Don Massey Family Foundation Emergency Critical Care Center, or to be short, to say EC3. So for now, I want to say EC3. Okay, this opened about 2 years ago, February 15th of 2015. And again, building upon previous lectures, Dr. Silvergray talked about why. Starting off with why as the core. So why did we build the first ICUs in an ED? Okay, well, at the time, it's been almost 2 decades ago when we had a crossroads between our two specialties, emergency medicine and critical care. There was a publication of a bunch of critical care panels of experts looking at a critical care staffing model upstairs in an ICU, and found out that at that time there was a huge shortage in critical care professionals, critical care intensivists as well as nurses and ICU beds for that matter, to take care of the needs back in the late 90s. Now that need has only increased, and there hasn't been an increase in intensivists during that time. So that shortage has only gotten worse. At the same time, we all know, because we experience this every day, that we have that same type of pressure in the emergency department. The emergency department was at a state of crisis in the late 90s from an increased volume and increased acuity, and that has only gotten worse in the past 2 decades. So both of our specialties have gotten, increased amount of critically ill patients that need to be cared for, in a timely fashion. Unfortunately, there hasn't been any good solutions to this in the last, 20 years. So this was the impetus behind creating an emergency critical care center. We brought the ICU down to the emergency department. This way, we can treat these patients in a fashion that can, start critical illness therapies, right when the patient needs. Patients have been typically waiting in the ED for up to 4 to 12 hours for an ICU bed on average. Studies have shown that the longer that they're down in the ED, the magic hour being around 4 hours, mortality starts to increase. So by creating a center to where we can take care of these patients in the ED, we hopefully can make an impact on the outcome of these patients. So that was the impetus of the why we do this from a clinical and from a societal need. Now, another part about this was critical care research at the time. So critical research was hard. It's hard to enroll patients. It's hard to screen for these patients. A lot of times these patients start in the ED. The only time that they are able to get enrolled in trials typically is when they get admitted to the ICU. And as we talked about it earlier, these patients can wait in the ED for sometimes up to 24 hours. So usually at that time, all the critical care trials had an enrollment window that sometimes reached as far as 48 hours. Well, as you can imagine, if you have a critical illness, there's a lot that can happen in that first 48 hours. So the emergency medicine research right along with this was also difficult. A lot of times if you had critical illness and you had a grant or you had some funding, to study a certain disease process, you geared up to enroll those patients in the ED. As soon as that funding went away, though, a lot of those resources went away with it. And so you had to continue to train patients, or to train faculty, to train nurses, to train staff to how to take care of these critically ill patients. So from a research standpoint, the Emergency Critical Care Center, EC3, is now formed to create a mission, not only of taking care of our patients, but also from a research standpoint. And so one of our top goals, we look back at this when we came up with our mission statement, several years ago, one of the top goals for this was to expand on our clinical care research infrastructure in synergy with our newly established Michigan Center for Integrative Research in Critical Care, or MCIRC, in order to study these patients in a timely fashion. And we wouldn't have to retool up every time a study came around. We were there, the infrastructure was there. Now, we also wanted to, of course, to provide an infrastructure, for a critical illness that's not only related to our own a center, but also for other studies that are going on as well in the field. And then partner with current emerging critical illness research pipelines that we already had, in store, like the NET network and our Trauma and Burn Center. Now, the other missions of this, only for research, I'll just touch quickly on these, was to facilitate collaboration with our critical care providers upstairs to provide the care that these patients need. Okay, that actually is fairly self-explanatory. They wanted to get the best care. Along with that, we wanted to increase the exposure from our educational opportunities to our residents, to our med students, to our fellows, to see what this acute phase looks like. And then ultimately wanted to create a center of excellence and maybe regionalize critical care starting from the emergency department from the ground up. And these were our missions, and these were the goals, and this really was what was fueling the EC3 in its infancy. Now, how did we do this? So, as Dr. Richardson talked about, collaboration really is key. We formed an emergency critical care advisory committee before we even had bricks and mortar started, on the building process. We brought all the directors of the ICUs together, including the emergency department, and we came up with certain clinical pathways and how we're going to manage these patients and what we're going to do. So at least the ground structure of caring for these patients wasn't something new. We knew how to take care of this. This was part of the infrastructure. This is really what we've been working on for the past couple years. And now the next step is really gearing up for the clinical trials. So now we know how to take care of these patients, we know what to do, and now we can go into the clinical trials. Now, what type of patients do we see? Well, we see around 7 patients a day, around 220 patients a month. You can see the majority of the patients are falling in either to the sepsis or to the respiratory failure category. And ironically, the majority of the patients go to the floor. They don't go to the ICU. Only 30% end up going to an ICU. In the past couple of years, you can see some of these interesting, acronyms, Euphrates, Euphoria, BMS. These are all some of the clinical trials that have started off in the emergency department in the EC3, or at least we've been rolling in them down there. We've also had a lot of investigator-initiated studies that have gone on, in the ED. A lot of these are a novel thinking about acute illnesses that we have seen a long time, but now we can apply our process down there acutely in the emergency department rather than waiting upstairs. And then I want to talk about now the next phase is some of the NIH and the federally funded grants and trials that we're doing. So there's 3 of them that are currently ongoing. The first one I'm going to talk briefly about is PEDAL. This is our largest one that we've been enrolling now for over a year. This is NHLBI Clinical Trials Network at 12 centers and 1 clinical coordinating center. It's going to go from 2014 to 2021. It's also the first center that has our clinical trials research group, which I think they're all sitting right there. Wave, everybody wave. Okay. The idea about this is to look at patients with acute lung injury, try to identify these patients early, and then see if there's some type of diagnostic or therapeutic intervention that we can do early on in their disease state rather than waiting till later. This is building on previous findings that we have from the network, from the ARDS network that was over 2 decades ago as well, and then also develop a collaborative working nature between the ICUs and the emergency department. So this also is one of the first initiatives to bring our 2 specialties together that's funded by the NIH. So that's actually very important, and actually it's very exciting. Now here's an update on the PEDAL trial. We just had a meeting last week in Denver, and we, as you can see from our graph here, here's our total. We've enrolled about over 593 patients. So we're above projections. Our total enrollment is expected to be close to around 1,500 patients. So we're about a third of the way, a little over a third of the way there. We're above expectations. And we are actually doing well on the Michigan side. So this is what we have here at Michigan site. We have multiple representatives from multiple specialties: pulmonary critical care, surgery, emergency medicine, etc. Christine Nelson is our study coordinator with this, and again, our clinical care trials network is also running the study. We do have 2 spokes, Henry Ford Hospital, and then we just brought on Indiana University to help with the trial as well. We have 39 patients enrolled since November 16, which puts us in the top half in this last quarter. So actually we're doing pretty well. And a lot of these patients are being screened and enrolled in the emergency department in the EC3. Now, some other trials that are coming down the pipeline in the PEDAL network, this is a network now, remember, so we're going to see several of these. We have a Primrose trial, we have a Pete Rose trial, and remember, these are where all these funny names come into play. A lot of these haven't started yet, we're still in the process phase. We have a Red Rose trial, then we have a Violet, which is actually our next trial coming up, and we're actually going over the process now through the IRB to get that up and running. That's with using vitamin D to see if the inflammatory modulation that can happen with high doses of vitamin D can decrease inflammation. And that's going to start here pretty soon. And then we talked about Clovers. Clovers is another trial that's about a resuscitation trial that could be potentially very exciting, is about vasopressors versus fluid. Some of the details are still being hammered out on that one. Other NIH-funded trials, a network is the Siren network, which just was announced. We are going to be a part of the Siren Network. This is going to be run out of Wayne State. We are going to be a spoke with this in this large network, including Metro Detroit as well as Ann Arbor, the University of Michigan. And then the last one, Dr. Newmar and Dr. Bartlett have come together to put together an ECPR, or an ECMO-based trial looking at patients in refractory cardiac arrest. This is one of the first trial, actually the first trial to try to address the question. And if a patient has refractory out-of-hospital cardiac arrest, if we can put these patients on an aggressive supportive type of therapy, such as ECMO, will these patients do better? And if we can get this on in a timely fashion within 60 minutes, what's going to be the outcome? The current case reports seem to think that, or seem to show that if we can get patients on an extracorporeal support within about an hour, patients do well. We're actually going to study that, and this in this pilot trial grant, to see if this actually pans out. Now this is very collaborative, including cardiac surgery, emergency medicine, neurology, cardiology, HVA. So this takes a lot of people, a lot of moving parts. Jennifer Fowler, our research coordinator, has been working extremely hard with FDA, with the IRB, getting all the ethic studies or paperwork that needs to go to get this trial underway. We're going to start this May 1st. So in summary, the Massey Family Foundation, or the EC3, this provides really an excellent patient-centered acute critical care platform, not only for education, but also for taking care of patients. Its infrastructure really is designed and it's built for clinical research, and going forward, it really provides the groundwork for doing these very difficult acute critical care clinical trials that are going to shape our specialty for our sickest patients. Thank you.
Thanks, Kyle. Questions for Kyle about the EC3 and pedal? It seems there seems like to be a number. I can't even keep track of the number of trials that you seem to be recruiting through in the EC3 at any given time. I mean, right now there are 5, 6 trials. It looks like
there are several. Yeah, it's hard to keep track of, but at least 5 or 6 active ones, and they're all in the process of having new ones come on board as well.
Yeah, it's really exciting. Anybody else have any questions? No. Thanks for your time today.